thank you for inviting me to be with you today. I applaud the conference organizers for their focus on the population determinants of health in aging with HIV, and I'm delighted to provide a social epidemiology perspective to kick off this conference. So these are my disclosures. So I'd like to start with just 3 simple questions to really get us primed and ready to talk about population determinants of health. First, what are social determinants of health and why are they important? So we have to think about this in 2 separate concepts. First of all, individuals. So in clinical medicine, we want to prevent a health outcome in a given patient. And so the determinants of that individual having an outcome is really it's a specific thing to look at those determinants for outcome within that person. What's their age? What's their sex? Do they smoke? Different things like that. We want to protect our most vulnerable, so we look for our highest risk patients, and we think that's where we need to intervene. For example, if someone comes in, they have a number of lifestyle risk factors and other things that we think, maybe this individual is going to develop hypertension or their systolic blood pressure looks high, and so we're going to ask the questions, what do I need to do for this patient now? And maybe it's antihypertensives. So all of this is within this focus in this realm of why do some individuals have hypertension? But when we move to a population perspective, we start to wonder about the determinants of the incidence of that outcome in a population. So an individual's risk is definitely going to be intertwined with the population risk, but the question is different here. The question is, why do some populations have much hypertension whilst others it is rare? So that's a direct quote from this very important paper by Geoffrey Rose, Sick Individuals in Sick Populations, that lays out this concept that population health is different than individual level health. And here in the figure that he shows in his paper, there's a population from Kenya, there's a population from London, and the x-axis is systolic blood pressure. And we see that overall, London civil servants have a distribution shifted to higher systolic blood pressure than Kenyan nomads. So asking these questions about individuals is one thing. Asking questions about populations means that we should be focusing on interventions at a population level as well. So social determinants of health have been defined by a number of leading health authorities, including the WHO, defining social determinants of health as non-medical factors, conditions in which people are born, grow, work, live, and age. The CDC has a place-based perspective on social determinants of health. So these are the conditions in the places where people live, learn, work, and play. Regardless, social determinants of health have an impact on health. These are things that we know influence health. And here you see that demonstration of the CDC's place-based framing of social determinants of health, and they have 5 key areas that you can see here in the different colors. So social determinants of health are really large forces. They are external to an individual. And I think one of the ways that it helps me to conceptualize this almost immediately is from Greg Millett's paper, and I'm excited to know that he'll be talking later in the conference. But after his great talk at CROI in the summer of 2020, he put together this JIAS paper where he stated Black Americans remain more likely to acquire HIV despite greater HIV testing and fewer risk behaviors than white Americans. So he's saying, you know what? Even if we ignore the individual level situation that's going on, right, in which, by the way, risk behaviors could still be lower, but Black Americans are going to have this higher risk of HIV. That points to these bigger factors that are playing a role here. That points to the idea that individual level or intervening upon an individual is not necessarily going to solve these problems. There are a number of different frameworks for social determinants of health, but I'm going to show you 2 that I think could be easily applied to aging with HIV. They're broader frameworks because when we talk about aging with HIV, we do talk about that full life course and an individual's accumulated exposure to these social determinants of health. This is one such framework. The thing I like most about this framework is the social and community networks is clearly drawn out, and we know in persons aging with HIV, we have a lot of evidence to show that influence of social and community networks on individuals' health as they continue to age with HIV. Here's another one. So this framework is a little bit more streamlined. It has medical care and personal behaviors as those individual level risk factors, but then really the social determinants of health are coming up in the two broader levels: living and working conditions in homes and communities, and economic and social opportunities and resources. It's important to note that the CDC has started to incorporate social determinants of health in our HIV surveillance data, right? So how have they done this? They take two geographic levels, the census tract level and the county health level, and they use these two different levels to have these measurements of poverty, education, economic stability, employment status, health insurance coverage, and housing. Now, these are not individual level measurements. Rather, they're looking at the proportions of the population, or for example, the median household income in a specified geographic area, either at the census tract level or the county level. So this helps us to understand that these are forces measured outside of the individual at the population level, but they are definitely influencing HIV incidence in these different counties and by these different social determinants of health. In HIV, a number of social determinants of health have been critically looked at, including income, unemployment, homelessness, racial segregation, incarceration, healthcare access, transportation, racism, discrimination, stigma, social isolation and exclusion, maltreatment by law enforcement, and trauma such as AIDS survivor syndrome. And I love this figure that just reminds us that all of these social determinants of health are at play when we look at any of our care continuums. When we look at any of our measurements of population health, whether we're explicitly acknowledging them or not. I love this blue bar before the bars, this big bar that reminds us that these social determinants of health are at play in all of the individuals and populations that we are following through this care continuum. I also just want to make a quick note that social determinants of health, these individual ones that you see listed here, may impact different subgroups of persons with HIV. Here in the US, our HIV epidemic is very heterogeneous. We have different populations that have disproportionate burdens of HIV. And these subgroups may have a social determinant of health that is more influential in one subgroup compared to another. And we'll talk more about that. So why are social determinants of health so important that we're having a whole conference about them specific to aging with HIV? Well, a recent National Academy of Sciences report suggested that as much as 70% of health outcomes stem from socioeconomic factors, physical environments, and healthcare. That is a lot. And as you see in this figure from this paper by Sandroglea and colleagues, low education was the force attributed to 245 deaths. Poverty, 133,000 deaths. Low social support, 162,000 deaths. And this is in the United States. So these are major forces that are having huge impacts. And the question is, how do we address them? So how do social determinants impact health in people aging with HIV? First, we have to recognize that social determinants of health are often thought about as upstream factors, right? They're the social and structural conditions that shape the nature of our social networks. And our social networks provide opportunities for psychosocial mechanisms, and those mechanisms impact health through pathways. And eventually, as we're at that downstream moment, we're looking for those mechanisms. We're looking to draw these lines, to create these links. But as you can tell, we're starting with social and structural conditions, things that are tough to measure. But this is what we have to do in order to really understand how social determinants of health are impacting health and know the right points of intervention, being able to predict if we intervene here versus here, do this versus that, we could perhaps get a better outcome in terms of population health. Social factors do get under the skin, right? That's how this social determinant of health process works. So bodies biologically express the social conditions they experience. This happens over the life course. It happens across social gradients, and that's what gives rise to disparities in health inequities. It points to biochemical processes in these candidate systems that may be affected. And so now we've not only added into the challenges of measurements, but the challenges of measurements over time, right, over life course, so that we can then also work towards identifying these mechanisms, which can also be hard because these are multifactorial processes. And social determinants of health that start way up here are going to manifest differently in bodies down here. And how do we relate all of these different steps? It does become complicated, but as with any complicated process, we have to start taking the small chunks, the small steps to build that rigorous science. And that has been done over the course of a number of decades now. So it's our opportunity to build upon it. In aging with HIV, there have been some simplified pathways to comorbidities. We've said it could be the virus itself. We've said it could be the ART. And we've said for a number of years, it could be lifestyle. Well, actually, it's not just lifestyle. It's much more complicated. It's the social determinants of health that impact our health outcomes, including what is going on with an individual, but also in the broader scheme of things. So for example, if we're looking at an individual and we say, you know what, they're gaining too much weight with their ART initiation, and in subsequent years after that, we really need to get them onto a better diet. We need to talk to them about diet. Well, if that individual lives in a food desert, you can talk all you want. It's not going to help them get access to the fresh fruits and vegetables and other nutritious resources that they need. So this is the place where social determinants of health come into play. It broadens our understanding and helps us to realize that if we tackle those bigger things, we may get bigger results. Social factors influence over the course of a lifetime, but there are frameworks and ideas about when different social factors may result in a greater influence on some sort of health outcome. For example, latent effects, early life environmental effects, and later health outcomes. If we think about the cultural norms around smoking, different places in the country, and smoking at younger ages, the use of nicotine to cope with stress, how that may influence an individual as to when they start smoking, and then those longer term effects over time of what happens for individuals who started smoking at 14, 15, 16 and may have had an even greater intensity of smoking or longer duration of smoking, and what that means for their comorbidity profile later in life. A critical period, this has an interesting example of the fetal origins of obesity. So how we've drawn the lines between diabetes during pregnancy and the differences in what passes through the placenta, whether it's just glucose or it's glucose and insulin, it's not insulin, and how that affects the fetus. And then once that fetus is born, and how their obesity risk profile is different over the course of their lifespan based on that in utero exposure. That's this idea of a critical period influence of a social factor and longer term outcomes. And then there's also a sensitive period. So this is a time when an exposure has a stronger effect on the development or subsequent disease risk. So thinking through childhood trauma and what childhood trauma and how childhood trauma has been linked to intimate partner violence later in life. Life course and comorbidities. This is really the challenge of understanding the whole person as they age and how all of their life experiences are going to impact their comorbidity burden as they're aging with HIV, and then being able to parse out where the social determinants of health are at play. And it starts at birth, right? It starts with poverty, with race, with ethnicity, through early life, just as we were talking about during that earlier period, and can lead to more latent outcomes later in life, education, trauma, social isolation. Midlife, we have obesity, but it's not just obesity, right? It's access to fresh fruits and vegetables. It's access to education in early life. It's access all along the line that leads us through this pathway to later life. So this idea of life course is very much at play as we approach social determinants specific to populations aging with HIV. Access to healthcare. So let's take a moment to pause now that we've kind of outlined how these social determinants of health are working at a broader level and over time, to think about, okay, access to care. So access to healthcare in persons with HIV, this was a study out of the HOPS, and it showed that individuals with public health insurance have a greater number of comorbidities. They have a greater risk of having a greater number of comorbidities as compared to those with private insurance, or those with self-pay or no insurance also have a greater risk of a greater number of comorbidities compared to those with private insurance. So what is this telling us? Well, it's telling us that access to healthcare is important. But we know that within HIV, there are lots of different ways individuals can access care. There's Ryan White, there's Medicaid, and now as individuals are aging, there's also Medicare. So what if we hold those structural barriers to care constant? Things like insurance status or payer status, right? Let's hold that constant for a minute and take a look. So let's go into Kaiser Permanente, this beautiful study by Julia Marcus and her colleagues out of Kaiser Permanente, Northern California. This is a group of individuals who all have Kaiser Permanente health insurance and seek care through the Kaiser Permanente care structure. Here are your overall and comorbidity-free life expectancies in people with and without HIV. So first, this is life expectancy in people without HIV, the top line. People with HIV, we know, have slightly lower life expectancy, and it's improved over time. That gap in life expectancy is narrowing. But notice here, the gap in comorbidity-free life expectancy is not narrowing. It's not narrowing in people with having, once we hold this access to care piece through insurance, very, very constant by looking this population of Kaiser Permanente. And the authors of the commentary that went along with this paper note it, right? They say the observed differences in the overall and comorbidity-free life expectancy are almost certainly underestimated for individuals with HIV infection who have reduced access to care and unfavorable social determinants of health. And so this is an important subset of individuals, and perhaps not just a subset, but many subsets of individuals that are impacted by the complex, as they state, interrelated personal and public health challenges, including things like racism, stigma, housing instability, all of these major social determinants of health. And so this is where we're at. We have maximized ART in terms of life expectancy, and now we have to focus on, especially as people are aging with HIV, the social determinants of health in order to really start pushing the gap to narrow it in comorbidity-free years living with and without HIV. But we know that this is hard, and that there are other barriers than just payer to accessing ART. Again, these are the social determinants of health. This was coverage of what's the reality of the Ponce de Leon Center right there in Atlanta, where I know this conference is run out of. And what we see here is this issue that individuals are having trouble accessing care, and stigma is one of the biggest barriers now. So it's not getting people into ART, into treatment and therapy because they didn't have a payer. Now it's bringing them in to overcome those barriers of stigma. We should also note that social determinants of health are different by different subgroups. And here we're looking at women in the Ys, and we're seeing that individuals comparing positives and similar negative women, individuals with HIV definitely have a greater burden of comorbidities. These women do, but we see a number of factors that are influencing those comorbidities that we know are related to social determinants of health, right? So race, obesity, income, cigarette use, other substances, all of those resulting in this greater comorbidity burden. So these are the pieces, these are the steps that we're starting to link these factors back to these greater social determinants of health. So when talking about gender, transgender individuals are another important subgroup. And we see here in this work coming out of Puerto Rico of transgender adults, both HIV infected and uninfected, we see the impact of social determinants of health in their lives with a high level of unemployment and poverty, difficulty accessing care, discrimination experienced at work or when buying or renting a house, intimate partner violence, violence in a public setting. It's important to realize that these are the impacts of social determinants of health that will likely have negative health outcomes. It's also important to note the last bullet here, 66% have support from family members. So it's also important to dig into these perhaps positive social determinants of health and how they can positively affect different health outcomes, because we're going to need those to help inform intervention. So racism is a very high upstream effect that is going to flow all the way down. It's an important social determinant of health. in Greg Millet's piece, he outlines the different pathways, and you can see it flow through, you can look at these pathways and say, these are definitely, again, structural pathways. So it's, structure upon structure in understanding how these social determinants of health will then flow down to the individual level. And when you think about an individual aging with HIV who may be Black or brown or Hispanic ethnicity, you're realizing that racism has accumulated over the lifespan. And so it's important to recognize these pathways. They're present in HIV. In Greg Millet's paper here, he was also making those parallels to SARS-CoV-2 or the COVID epidemic, where the light has really been shined on a lot of these pathways. So social isolation, let's stop here just for a minute to talk briefly about this, because this is really key in adults aging with HIV. We know there are numerous mechanisms for social isolation and numerous health outcomes. And I also want to make a point that social isolation is an evolving, changing thing over time in a person's life course, and that we have studies that show social isolation is high among younger people with HIV, and that some of those mechanisms are slightly different than among older adults with HIV, who are pointing to things like AIDS survivor syndrome as one of the more major mechanisms, whereas among younger individuals, stigma still seems to be the highest, right? So we need to make more progress there. But all of these social isolation mechanisms are then linked to these health outcomes of things like disrupted sleep, stress hormones, etc. And I think the question that we have to pose to ourselves is, are we going to give a patient a sleeping aid, or are we going to try and tackle stigma? I think we have to do both, right? But we also have to recognize that stigma can't be the afterthought, right? It has to have just as much focus, just as much attention, and be just as rigorously vetted, studied, and interventions prepared for. Social isolation has been studied in a number of contexts, and I want to just point out 3 studies. So first, in the study on the far left, where we're looking at the socially connected, the minimally isolated, and the socially isolated, we see a 48% increase in all-cause mortality, in the odds of all-cause mortality in individuals with HIV. That is hugely significant. And when we start to tease out these factors, we can turn to Meredith Green's work, where she looks at loneliness, and she sees this increase in poor or fair health-related quality of life with increasing loneliness, but also depression is playing a role. And they note that it is really important for longitudinal data to test for mediation and better examine the complex relationships between loneliness, depression, isolation, and stigma. And then finally, this paper from the WISE that showed internalized HIV stigma flows to social support, to depressive symptoms, and then down to adherence. So this mediation pathway is so key. And they conclude HIV-related internalized stigma has an indirect and negative effect on adherence for women living with HIV, mediated by social support or loneliness and depression. So then the questions become, where should we be intervening? How should we be intervening? The social support intervention, that's a structural intervention. Depressive symptoms, that might be a medical intervention. So thinking through how these social determinants of health also need to play with and interact with individual level interventions is key, but remembering from the social epidemiology perspective, the focus is going to be on those structural interventions. So in our remaining time, let's talk about how we address social determinants of health, approaches to interventions on social determinants of health that impact the health of people aging with HIV. So first, financial stability. So this study that happened in Stockton, where 325 randomly selected people who were living below the median household income in Stockton were selected. And among those individuals, 125 were given $500 a month guaranteed income. And this is an ongoing study for 2 years. After 1 year, tremendous results: 12% increase in full-time employment, increased productivity, decreased stress, overall improved well-being. Now, there are no guaranteed income studies in persons aging with HIV to my knowledge. There are income generating studies and cash transfer programs in broader studies of persons with HIV, not necessarily those aging with HIV. And there's some mixed reviews, and I think that might be because in those studies, you're not necessarily tackling financial instability and reducing instability directly, because there are other things that can come in the way in income generating studies and cash transfer programs just by the mechanism of the intervention. When we're doing these financial stability studies, there are a couple of key things that we really have to dig into. First of all, community level randomization would be really key in order to have the most rigorous design. Macroeconomic outcomes are also really important, but can be really hard to measure, but absolutely key for understanding those spillover effects. And then finally, modeling studies may play an important role here in understanding how reducing financial instability may improve health outcomes among persons aging with HIV. Housing. Housing is healthcare, and we know that. Even from randomized controlled trials, this one noted here of homeless individuals, for every 3.25 homeless individuals who were hospitalized and had HIV, at 3.25 housed meant one would survive. And that's an amazing return on being able to house individuals and actually keep them alive. There are resources for individuals who are aging with HIV, including the housing opportunities for persons with AIDS, which is run out of HUD, but perhaps expansion of these services are going to be needed to better meet the changing needs of people aging with HIV, because there are new challenges coming. Nursing care facilities. Preparation of nursing care facilities to care for people aging with HIV is going to be really important, and it's not just passing ART medication, it's also understanding the extent to which support for substance use issues, overcoming social isolation and addressing AIDS survivor syndrome within these populations, and overall just ensuring an inclusive and friendly environment for individuals across the LGBTQ community. In-home care is also something that needs to be thought about deeply, and support services set up specific to individuals aging with HIV, as well as support for those in-home caregivers, persons aging with HIV, oftentimes family members. And then finally, supportive housing, right, with this emphasis on social isolation in order to ensure that that housing is appropriate for an adult aging with HIV. To study the impact of food security on persons with HIV, a study provided meals and snacks for 6 months among adults with HIV and adults with type 2 diabetes, and these were programs that met daily energy requirements and nutritional guidelines, so good healthy foods provided for these individuals, and they saw a decrease in depressive symptoms, binge drinking, sacrificing food for healthcare, or sacrificing healthcare for food, and an increase in ART adherence. So very compelling results that reducing food insecurity can improve a number of different health outcomes. There are food programs that are available nationwide, including Meals on Wheels and different congregate meals and home delivery meals offered through the Older Americans Act. It's important to note that the age cutoff is 60 and above, whereas in persons with HIV, oftentimes 50 and above is considered older Americans. So perhaps there's an intervention here to suggest individuals with HIV 50 and above could be accessing these different programs. Also, state level designation for older adults with HIV as a targeted population for greatest social need. This is happening in a few states. If it happens in more and more states, we could hopefully see the stronger force to perhaps reduce the ages at which Older Americans Act covers meals, or Meals on Wheels covers meals. And then finally, although it doesn't provide a long-term solution, restaurant donated meals for social event prizes among adults aging with HIV have been shown to be quite popular in some research and in anecdotal evidence. Law enforcement reform. So the Journal of the AIDS Society, International AIDS Society, definitely had an amazing issue come out in July 2016 that specifically looked at policing practices and how they're important structural HIV determinants, specifically for sex workers and people who use drugs. As the whole nation kind of continues this process and this collective trauma of understanding what happened to George Floyd and the trial that is ongoing now, we also need to remember that there are examples of interventions with police forces that have resulted in very positive things happening for persons with HIV, like the UK guidance to police media on needle and syringe programs, the Vancouver Police Department drug policy approach that does have a harm reduction strategy for persons who use drugs, and then even using the probation system as a source and a sense of HIV testing and referral for social services. If we do that systematically, individuals can get the care and the support that they need when on probation. So I think there are things to think about here with law enforcement reform. in the broader scale, but also very specific to individuals with HIV and aging with healthcare navigation and delivery. There is definitely room for structural intervention here. There are age-specific care navigation and support groups that are great templates. I've listed a few here, but when it comes down to how we care for older adults aging with HIV in the clinic, I think we have to be very real that there is an absence of an evidence base to show how care should be provided to older persons living with HIV, as expressed in this JIAS paper in 2018. So we need to rethink some of these models of care. We need to think about care coordinators because the number of people aging with HIV is surging, the demand is growing, and yet the number of clinicians who are going into HIV is declining. We need gender affirming and trauma informed care and thinking through how we need to modify care for that. We need in-home skilled nursing and adult day programs for people aging with HIV. St. Mary's in Harlem has been an amazing example of that. Co-locating healthcare providers has really resulted in some very good health outcomes among adults aging with HIV. But then when we're also thinking about that structure of that clinician and patient interaction, creating a framework where we're adopting geriatric frameworks even at younger ages to create that patient-centered care. Karis and Erlandson have noted the 6 M's: mind, mobility, medications, multi-complexity matters most, modification of lifestyle risk factors. This kind of framework for care, I think, is something that we have to consider as we move forward with the modifications needed to ensure that we're meeting the needs of adults aging with HIV. And finally, this is structural, right? Social determinants of health require structural interventions, and Greg Millett had an amazing call to action, a Marshall Plan to tackle inequities across health and other sectors, create economic, housing, and educational opportunities. And he was speaking specifically to Black and Brown communities, and we know how racism is such an upstream factor that is really key. But I think this call to action applies to increasing economic, housing, educational opportunities by gender, by a number of other categories that people identify with. But the challenge is to really make sure that evidence is there to guide social policies, that it's rigorous, comprehensive, and similar to what we use to inform clinical interventions, because social policies must deal with those upstream factors. Beginning to answer this big call is really the American Rescue Plan. So this is a very extensive plan, which is hopefully not only going to rescue us from some of the negative impacts of COVID, but also the negative impacts that have been accumulating over time now for decades due to these different, the impacts of the social determinants of health. When we think about what is in that plan, you can draw those lines between direct payments and unextended employment benefits to financial stability. Sadly, the minimum wage raised to $15 an hour, that was cut, unfortunately. But things like secure housing and water, expanding federal nutrition programs, expanding access to behavioral health services, gender-based violence survivor services, and ensuring those services are available in underserved populations, focus on incarcerated populations and public transit. These are the ways that we intervene at that structural level so that we can see better downstream effects when we help reduce some of the negative social determinants of health. And then finally, the CDC has just noted that racism is a serious threat to public health. Again, a social determinant of health way up in the upstream area of life. Racism is not just a discrimination against one group based on the color of their skin. It is structural barriers that impact racial and ethnic groups to differently influence where a person lives, where they work, where their children play, and where they worship and gather in community. So this recognition by the CDC just very recently to say we're digging in here. We are getting into this to understand how the social determinants of health have lifelong negative effects on individuals and specifically in communities of color. This is the moment. This is when we all need to dig in and start to identify how we can intervene on social determinants of health in order to improve the lives of persons aging with HIV. I'd like to thank you for having me today. I would like to thank the people who allow us to collect our data through our studies of HIV and the NA Cohort, IeDEA, MaxWise, Alive, VAX, all the different cohorts that I've had the privilege of working with, all of my colleagues that have influenced my understanding of aging with HIV, and my colleagues, particularly Lori Dean and Arunda Chandran, who have really been helping me to understand and grow my knowledge base and understanding of social determinants of health from a social epidemiology perspective. So thank you for having me.